This week on the BackTable podcast.
That's one of the potential things to think about is, okay, this person's had a fantastic response in their distant sites of disease. Maybe there's still some residual disease in the pelvis somewhere, whether it's in the index tumor in the bladder or in a pelvic node or both. And can we consolidate that surgically and sort of achieve a number of different goals? Get some pathologic staging, definitive assessment of their local state of their disease. If we think through, borrowing some concepts from kidney cancer and the role of surgical consolidation there, could there potentially be an oncologic benefit to controlling the primary? These are sort of the proposed ideas that have led to some of these discussions. But this is, again, not based on any kind of, phase 3 randomized trials that tell us, okay, yeah, surgery is definitely the right thing to do. This is so in the weeds, roll up the sleeves, have the discussions at tumor board, talk to the colleagues and say, okay, we're in a conundrum we haven't been in before. These patients are doing so much better than they have. And for some of them, surgery does make sense.
My name is Dan Roberson, and I'll be your guest host for today's episode. I'm a urologic oncology fellow at Mayo Clinic in Rochester, Minnesota. I'm very excited for today's episode. We're going to be talking about consolidative surgery in patients who have advanced urothelial carcinoma and who have received induction antibody drug conjugate therapy and immunotherapy, more specifically Enfortumab, Vedotin, and Pembrolizumab. I'm even more excited to be joined by a mentor of mine, Dr. Abhinav Khanna, who's an assistant professor of urology at Mayo Clinic and a urologic oncologist. Dr. Khanna treats the full spectrum of urologic malignancies, though he specializes in bladder cancer, prostate cancer, and kidney cancer. I personally think Dr. Khanna is a very thoughtful clinician and has a lot of great insight on this topic, so I'm really excited to share our discussion today with the listeners, and I hope everyone enjoys it and gets a lot out of it. So without further ado, Dr. Khanna, thank you for being here, and welcome to BackTable Urology.
Yeah, Dan, thank you so much for having me. Really excited to be here, really excited to chat with you.
Awesome. So let's get started. Let's jump right in. I first want to start 10,000 foot view, big picture. How did we get here today? And by that, I mean two urologists talking about operating on patients that have metastatic bladder cancer that pretty uniformly would be a diagnosis where patients would not live very long after. And now we're talking about operating on these patients. So why don't you just take us through big picture, how we got here, where we're even having this conversation today?
Yeah, great question. And I think it's one that really sets the stage for this discussion. So I'd say as urologists and as, bladder cancer surgeons, like our role in getting to this point has actually been fairly limited, to be fully honest. Like we kind of stumbled into this territory. And the reason I say that is because, as we all know, for a generation, the backbone of systemic therapy for advanced urothelial carcinoma has been cisplatin-based therapy, right? And so very much the realm of medical oncologists. And, to their credit, medical oncologists have really been pushing the envelope in terms of trying to identify new drug targets. Lots of things have been tested. Probably the most, prolific change we've seen in the paradigm for treating advanced bladder cancer or urothelial carcinoma has been with the arrival of EV-pembro, right? So the EV-302 trial came out a couple years ago, showed that Enfortumab Vedotin is just so much more effective than Enfortumab Vedotin plus Pembrolizumab, so much more effective than traditional cisplatin-based chemotherapy, and really overnight became the standard of care. Now, that's not really our domain, right? As urologic oncologists, we kind of are part of the multidisciplinary team, but we're not the sort of captain of the ship when it comes to folks who have metastatic bladder cancer. Historically, we've certainly not been, and I think we'll continue to not be. But I'd say, how did we get to this point? I'd say we stumbled upon it, and it sort of happened a little bit anecdotally, right? So, rewind ourselves a couple years, December of 2 years ago, EV-302 leads to FDA approval of EV-pembro first-line therapy in advanced metastatic urothelial carcinoma. And then boom, here we are. For the next 6 to 12 months, we're sitting at tumor board. We're talking about patients who have metastatic disease. They got EV-pembro. Now, all of a sudden, they've had a radiographic complete response, or they've had a much more dramatic response than anyone was expecting. And, maybe they're having some side effects from the EV or something like that. And someone raises the question of, okay, well, should we take out their bladder? And that's sort of essentially how this started. And I'd say we're really still in the infancy of this, but I'd say to answer your question in a very long way, how did we get here? It's, I think, because of such a really profound paradigm shift in the systemic therapy options and the outcomes of patients who have advanced disease.
Awesome. Yeah. And to piggyback off that, I want to ask you, you mentioned patients having some maybe symptoms on systemic therapy, but what do you see as the goals or the clinical rationale for consolidative surgery? Is it, local control, possibly related to cancer-specific outcomes overall, to survival outcomes? Is it treatment-free intervals? Is there some element of a quality of life benefit? Is it all the above? How would you describe the clinical rationale and, why we even consider consolidation?
Yeah, great question. I would say it's a little bit of all of the above. And to be honest, the answer is it's pretty heterogeneous. And so what I would emphasize probably to answer that question is that, we are really in such early stages of learning about this disease state and learning about sort of what's doable, what's not doable, what should be done, what shouldn't be done, what's oncologically the right thing to do or not. And I don't think we have answers to those. I think we are in a really exciting phase of this where we are asking questions. We are not yet answering those questions, and I think we're still learning. So I'd say the majority of cases, and we obviously wrote this paper together, highlighting our experience, retrospective paper, just highlighting 2 or 3 dozen patients who had consolidative surgery after systemic therapy for advanced urothelial carcinoma, right? So patients who historically haven't been your go-to candidates for a cystectomy or for nephrectomy. And I'd say the vast majority of those patients arrived at that decision to go to the operating room in a very multidisciplinary fashion. Tumor boards were almost always involved, medical oncology, urology, rad-onc, reviewing the images really closely with radiology, getting path involved. It's like true multidisciplinary decision-making is really the only way that we arrived at this decision for this first sort of cohort of a few dozen patients that we reported on. And I think, the rationale depends on the patient situation, but it's all those things you mentioned, right? So there's some folks who are having, classically like the neuropathy that comes with the EV can sometimes be bothersome, and maybe they've got to stop that, or maybe they're having some adverse side effects from both of the systemic therapies, and the medical oncologists are looking for maybe an off-ramp off of systemic therapy or even a holiday. Some folks certainly having still quite bothersome lower urinary tract symptoms, right, from the tumor, right? So in some ways to help address those. And then the elephant in the room, obviously, is the oncologic role, which, again, we are so early in this process, and I think we're still trying to learn about this and gather early data on this. But there's this question of, well, is there maybe some oncologic benefit? And I think the jury's still out, and we're a lot of work yet to do. But that's one of the sort of potential things to think about is, okay, this person's had a fantastic response in their distant sites of disease. Maybe there's still some residual disease in the pelvis somewhere, whether it's in the index tumor in the bladder or in a pelvic node or both. And can we consolidate that surgically and sort of achieve a number of different goals? Get some pathologic staging, definitive assessment of their local state of their disease. If we think through, borrowing some concepts from kidney cancer and the role of surgical consolidation there, could there potentially be an oncologic benefit to controlling the primary? Again, these are sort of the proposed ideas that have led to some of these discussions. But this is, again, not based on any kind of, phase 3 randomized trials that tell us, okay, yeah, surgery is definitely the right thing to do. This is so in the weeds, roll up the sleeves, have the discussions at tumor board, talk to the colleagues and say, okay, we're in a conundrum we haven't been in before. These patients are doing so much better than they have, and for some of them, surgery does make sense.
Yeah, and I like the fact that highlighting the true multidisciplinary aspect of the beginning of this work, I think is just so important. You mentioned that we're in the asking questions phase, and that resonates. I think that makes a lot of sense to me when thinking about where we are in this whole paradigm and how we manage these patients. So we're certainly going to get in the weeds with managing these patients and some of the limited data that we have available. Before we do that, I want to take one quick step back and talk about consolidation in the past. Why was it not a bigger component of managing these patients?
Yeah, great question. So I think the short answer is efficacy of the systemic therapy. But there's more nuance to that, right? So I would say it sort of boils down, and I usually, when I try to answer this question, I pull up the Kaplan-Meier curves from the EV-302 trial, and I say, okay, it's not that we never did consolidative surgery before. It's not like in the cisplatin era, nobody ever had positive nodes or distant disease, had a great response, and then for whatever reason had consolidative surgery. That's certainly been done. People have reported on it. There's series out there from the US, there's series out there from international settings, our European colleagues. This has been done. Again, it's all retrospective series for the vast majority of these papers, but I think it's a denominator issue. So in cisplatin, right, and if you look at the EV-302 trial, if you look out 18 months after their initial diagnosis and they get treatment, right? So patients who had EV-302, 40 to 45% of them still are going strong without disease recurrence. Right? They've not had progression. So that's almost half. So 18 months out, almost half of these patients are still having excellent response to treatment. You look at the number of patients who have that, who got cisplatin or who got chemotherapy, it's like 10, 12%, right? So almost 90% of these folks in the traditional chemotherapy era were having disease progression. And so if you think about sort of that number, you see a patient who's diagnosed with advanced urothelial carcinoma, they're seeing the medical oncologist. Oftentimes they're not even seeing us. They get diagnosed, they get, traditional chemotherapy, which is what we were using again for decades. 90% of those folks are going to have a progression of their disease in the next year and a half. And so you almost don't even get into the realm of, hey, you're seeing a great response. Let's send this patient to the surgeon and see if they think surgery makes sense. The number of patients who were in that camp was such a small fraction of the overall patient population that it was just done so much less frequently. Again, we did them, certainly we did them and we still do them on occasion, same reasons as we outlined before, usually multidisciplinary discussion. But the number of patients who were eligible for that, right? The number of patients who were not progressing, had stable disease, were having great responses, it simply wasn't to the scale that we see now.
Yeah, that certainly makes a lot of sense. So moving into management and moving into how to approach these patients and how to handle these multidisciplinary discussions and decision-making, let's start by talking about patient selection. I think this is one of the biggest challenges, at least that I grapple with thinking about in this population. So why don't you start by telling us in your practice, what are some of the rough criteria that you think about for an ideal candidate for consolidative cystectomy or nephrourectomy in this setting?
Yeah, great question. So the early sort of paper that we wrote on this and that others have reported on too is, I'll be the first to admit this, it is so heavily influenced by selection bias, right? So this is a very, very carefully selected patient population, which is paramount. And so in general, I would say these are folks who tended to have a very favorable response to EV-pembro or to their systemic therapy, right? So these are not people who had a few cycles of their systemic therapy and then at their next PET scan or their next cross-sectional imaging, the disease is very obviously progressing or blossoming with lots of new metastatic sites. That's usually not the situation in which this starts to come up. So I'd say the first is that they've got stable disease or an excellent response to their systemic therapy that seems to be sustained. That's a little bit of a wishy-washy answer because I'm not telling you like, okay, how many sites of disease or, there's not like criteria for that. Again, thus far, we're so early in this that it's been a little bit of a judgment call each time. But the idea is you don't want to operate on folks who are progressing on their systemic therapy because what those people really need is some second-line systemic therapy. They don't need to go to the operating room and have a big morbid operation. The other things are a little bit softer. These are a little bit more qualitative, but folks who certainly, if anybody's got bothersome lower urinary tract symptoms or is having, again, these are folks who are the whole spectrum of disease. So some of these folks presented with de novo metastatic disease. Some of these people, may have at some point had some local therapy to their bladder, TRBTs or something like that, and then maybe were lost to follow-up and now they're coming back. And so they may have some prior history with local therapy to their bladder. They may have some symptoms related to that or from the tumor itself. So I think if there's any degree of local symptomatology, I think that helps with the rationale. And then third, I would say, which is again paramount, and again, we borrow from our experience with cystectomy for patients with localized disease, so non-metastatic disease. You still apply all of that same clinical judgment, right? Is this patient fit enough to undergo a very big operation, comorbidities, all that stuff. And all of that is, I'd say, the same. It's the same sort of eyeball test that you do when you're thinking about offering someone a cystectomy for localized disease. And none of that changes. That piece of the clinical judgment is still super paramount.
Sure. So let's talk about the operation. What are the operations like in your experience? Are they the exact same as doing a case in a patient who's not received any therapy? Are they the exact same in doing a case in a patient who has received cisplatin-based chemotherapy? What have you found as you've done these operations?
Yeah, excellent question. So at the end of the day, it's a cystectomy, right? So nothing will change that very fact, which is that it's a morbid operation. And, it certainly comes with morbidity and I think requires some pause before you move forward with it. None of us who are doing this have done, a tremendous number of these. Like we put together our experience across all 3 Mayo Clinic sites with lots of surgeons that are doing this operation, and we scrounged up like less than 3 dozen patients. So, that just gives you a sense of scale. Obviously, we've done, I'd say, many more since that paper came out, but still, it's not like you ask about, what's it like doing a prostatectomy, which is, fairly commonplace for most of us. This is a relatively anecdote-based answer, right? So if you ask me for the anecdotes, I'd say for the most part, it's pretty similar to a, quote unquote, regular cystectomy for localized disease. The bladder, we initially, first couple, you're always worried, like, are they going to have some really horrific, like dense fibrotic reaction around the bladder or something like that? And I've not really seen that to be the case. I think it's sort of what you would expect for a cystectomy. And again, just based on anecdotes, sometimes in talking to folks who've also been doing these cases, I think most of us would probably agree, it's hit or miss. Sometimes the tissue around the lymph nodes can be totally normal. Sometimes it can be a little stuck, but certainly not prohibitive. We've not had to abort any cases or bail on cases or change plans or anything like that just because they got EV-pembro. I think these are still very much doable cases. And again, they come with the standard morbidity of what a cystectomy comes with. So again, the only real data we have on this that's been published is our paper, the short correspondence we put out in European Urology. And it was like 50 or 60% any complication, 18 or 20%, claving 3 or higher, if I recall. And so, that is probably on par with most contemporary series of cystectomy. It's not any easier because they've had advanced disease and they had systemic therapy beforehand, but it's certainly not, I'd say, qualitatively harder. I think it's still a morbid operation, but it's still doable, especially in, experienced centers who do lots of cystectomy. And I think that anecdotally, I don't think I've noticed that it's dramatically different in terms of the way the tissue planes handle or the way, that you approach the case.
Yeah, and I do think those numbers are all complications, and high-grade complications are very on par with what you see in all cystectomies. And I think that was reassuring, that finding, even in a small number of highly selected patients. So surgical approach, I know you do a lot of robotic surgery, but also open surgery. Minimally invasive, is it no different than to approach one of these cases as another cystectomy? If the patient's a candidate for minimally invasive surgery, otherwise, are you proceeding with a robotic approach?
I think my answer here would be do what you are most comfortable with, right? So if you are a primarily open cystectomist, and you do all your cystectomies open, then by all means do these open. And if you are primarily a robotic cystectomist and you like to do them robotic, then do that. And don't let the fact that they've had advanced disease in the past or got EV-pembro, don't make that a deal breaker. I think if you're comfortable with robotic cystectomy, by all means, you can do it. If you do a hybrid approach, robotic extirpation with an open diversion, it's basically, I would say, whatever you're already the most comfortable with. If you're out there doing cystectomies and you're comfortable doing cystectomies a certain way, approach these the same way. And I would actually say, don't necessarily change your approach just because of the fact that the patient had maybe a little bit more advanced disease. And I think, that probably fits what most of us do for kidney cancer too, right? So, we're not going to get into consolidative or cytoreductive nephrectomy, but most of us would probably do that. Like if you're primarily an open surgeon and you do open nephrectomies, you probably do your localized and your consolidative or cytoreductive nephrectomies open. But if you're a minimally invasive surgeon who does, minimally invasive nephrectomies and you do that for localized disease, just because the patient had advanced or metastatic disease and is now getting a cytoreductive nephrectomy, you probably still approach it minimally invasively for most people. And so I think the same applies here. So it's probably way more important to do what you're most comfortable with and what you and your teams are most comfortable with surgically than try and reinvent the wheel just because it's a slightly different disease state.
Sure, that makes a ton of sense. One of the other nuances that I'm hoping you can talk a little bit about is how is their fitness coming into the operating room? And are there any healing considerations or postoperative considerations that you found specific to EV-pembro? Patients who receive cisplatin certainly are beat up coming into surgery and it takes a toll on them. What do you see as the level of fitness of these patients coming into the OR? And then parallel to that, how do you work with the medical oncologist to time the last doses of EV and Pembro, and when do you restart these medications if they're planned to go back on them? Thinking about things from a surgical post-op perspective, with these two novel medications.
Yeah, it's a great question. Again, it's a hard question to answer with data. Like, this is maybe something that we did not address in our paper and that we've not looked at in any of the data that we've looked at in this topic, right? But now I'm going completely anecdote-based. And this whole talk is basically anecdote-based anyway, except for this little cohort that we put together. But this is like completely just based on our experience. I definitely will say the patients who've gotten EV-pembro are not as wiped as the patients who are getting cytotoxic agents. And let's say it's certainly no worse. So I don't want to commit to saying it's better, but it's certainly no worse, right? So it's certainly not like they are any worse off than the patients who get neoadjuvant cisplatin-based chemotherapy and then come for a cystectomy. There's a little bit less, again, just anecdotally, there's a little bit less of the, oh gosh, we had this person, scheduled for surgery, but they're still really anemic or they're still really neutropenic from their chemo, or they're really still debilitated. And, you're sort of like, gosh, do we wait a little longer? What do we do? And that's all cisplatin stuff that we're all used to. But I'd say there's a little less of that with the EV-pembro. People tend to tolerate these medicines pretty well. And again, I'm not a medical oncologist. I don't prescribe these drugs, but we operate on people after they've had them and they don't look as run down. I don't know how you quantify that, but when they come to your office before surgery, they probably look a little less run down than your patient who's getting cisplatin-based chemotherapy, even though they've got more advanced disease on paper.
So are you willing to take these patients to the operating room sooner after their last cycle of EV-pembro, or is it, whenever it logistically makes the most sense and they've had a little bit of time to recover, you're willing to take them to the OR?
Yeah, I'd say the way that, you don't have to necessarily wait for like blood counts to recover. They're generally not getting anemic, thrombocytopenic, neutropenic, all that stuff. And so that issue is a little bit less. I'd say, honestly, I really defer to the medical oncologists in terms of and a lot of it does end up being logistics, like when are they due for their next cycle? When are we able to get them into the OR? How do we time it? And I usually will defer to the medical oncologist and say, hey, how well are they tolerating the systemic therapy? How long do you think you can continue on? And when do you want us to do the surgery if that's the path we're going? And they'll usually give us a sense of, okay, we're going to do the last day of systemic therapy here. And then why don't you schedule the surgery in this window a couple weeks later? But I don't think we've ever had to postpone or something like that because they're not quote unquote recovered enough from the EV-pembro. It seems to not be quite the same as the cisplatin from that standpoint. And then your other question, in terms of getting back on it after, again, totally defer to the medical oncologist. But as you know, Pembro, these are not cytotoxic agents. I don't think we have the same degree of worry that we did, with some other types of systemic therapy. So it's basically depends on how their recovery goes and how keen the med-onc colleagues are to get them back on systemic therapy. But I usually don't object to whatever the medical oncologists want to do, to be honest.
Yeah, great. So let's move away a little bit from the surgery period itself, and let's talk about pathologic findings, acknowledging that any data in this space is very limited. But with that limited data and in your experience and what you've seen and talked to other urologic oncologists about, how would you describe the pathologic findings in these patients? And do you feel like you've seen anything preoperatively, whether that's clinical features, radiologic features, or something else that's predicted this pathology, predicted a certain patient's pathology?
To answer this question, I think is where we as a field, really need to continue to pool our data together, continue to publish on this, get the data out there, and then eventually really start running trials on this because, we can report what the pathologic results are. In terms of predicting who's going to have those pathologic results, I don't think we're there yet. So just to sort of give you a clear answer to your first question, like what actually are the pathologic results here? So when we looked at this, the way we sort of said was, okay, these patients all had advanced disease at diagnosis. They got systemic therapy. Most of them had a pretty favorable response to the systemic therapy, and then we take them for consolidative surgery. And so what did we find at surgery? 80% of these folks had some degree of pathologic downstaging. So what we found on surgical pathology at the time of their cystectomy, lymphadenectomy was better, obviously, than what their initial diagnosis was. So pathologic downstaging, 80%, which again, just speaks to how incredible this, cocktail of drugs is. So 80% downstaging, and then pathologic complete response, meaning after systemic therapy, no residual tumor in the bladder, no residual tumor in the nodes, and we're still doing node dissections for all these people, and we can talk about that separately, but complete pathologic response was like 43%, I think, in our first cohort. Again, 20-something patients. But that seems to be holding. Again, behind the scenes, we're working on a follow-up to that. That's a multi-center study across almost a dozen centers. And that seems to hold, right? It seems to be about the same. 80% pathologic downstaging, almost 40%, give or take a few points here and there, but almost 40% complete pathologic response, which is wild, right? That's like, and again, these are things that anecdotally we saw this to some degree in the cisplatin era, but just not to this scale. It makes you scratch your head because, and you hit the nail on the head with your question, your second part of your question, which is, how do you know, right? You sometimes get these PT0, Y0, YPT0, N0, whatever, and you're like, okay, that's amazing, but could we have predicted this pre-op? And that's where we simply don't have that answer yet. I don't know that we can predict. It doesn't see, again, anecdotally, it doesn't seem to line up always with their imaging. It doesn't always seem to line up with, not all these people had cystoscopies, but it doesn't always seem to line up with that, which is what we know, right, from trying to stage folks with muscle-invasive bladder cancer after neoadjuvant therapy. It is really hard to stage these folks. And so I think that still applies here. It's really hard to stage them locally. And then there are some pathologic quirks that, we don't fully understand. I think 3 out of the 28 or so patients who we looked at in our first cohort had no residual tumor left in the bladder, but still had a positive node, right? So like the T0N1 population, an interesting thing to see, no rhyme or reason. We've had folks who they get a PET scan, and we follow a lot of these folks with PET scan, but they'll get a PET scan that looks like, they've got a PET avid, node on their right pelvis, right external iliac, whatever, you dig it out. And it turns out that was actually pathologically node negative, but they had a small lymph node deposit somewhere in their left pelvis where it was completely dark on the PET scan. And so there's so many implications to that, right? Biggest implication, we really don't have like 100% reliable ways to fully stage these folks, and maybe ctDNA plays a part, but there's limitations there too. And the second is, lymphadenectomy is still paramount. You can't just say, oh, the nodes are negative, or there's one node that's positive or lighting up on PET scan, we'll just go pluck that out. I think there's implications here for how we approach these operations from a lymphadenectomy standpoint too.
And that's a great segue to talk about lymphadenectomy a little bit more in these patients. Can you describe the role that you see of lymphadenectomy in these cases? The paradigm has obviously shifted, at least in bladder cancer, a good deal recently with the SWOG 1011 trial. But do we need to be thinking about lymph node dissections differently in this population?
So obviously SWOG 1011, like what an incredible scientific effort by our colleagues, Seth Lerner and colleagues, truly to be able to pull off that kind of a surgical randomized trial and see it to fruition is incredible, and very rightfully so published in the New England Journal, right? This is like the pinnacle of scientific research and not so infrequently done in surgery because it's so hard to pull off. But when we think about patients who have advanced disease or even metastatic disease, it's a little hard to translate that. So SWOG 1011 obviously compared standard versus extended. So the first thing I'd say is SWOG 1011 should not be interpreted to mean that you don't need to do a lymphadenectomy. You certainly do, right? Because we're not asking no lymph nodes versus extended lymph nodes. We're talking standard lymph nodes versus extended lymph nodes. And if you are familiar with the trial, the folks who got a standard lymph node dissection, they're still getting a very excellent, thorough lymph node dissection. It's just limited to the pelvis. And so there's still a role, I think, in everybody who's having a cystectomy for whatever indication certainly lymphadenectomy still plays a part and still is the backbone of a good modern cystectomy. So, omitting a lymphadenectomy is probably not the way to go for anybody, unless there's obvious reasons to do that. So here, I think certainly these patients should still get a standard pelvic lymph node dissection, which is supported by SWOG 1011. The only, I'd say, caveat would be the patient population here is maybe a little bit different, right? So SWOG 1011 was generally going to be folks who had mostly localized disease. Obviously, there was some allowance for folks with advanced disease, but the patients we're talking about here in the sort of quote unquote consolidative setting have distant disease. They may have multiple nodes that are positive in the pelvis or even above. And if you are purely dogmatic about this and you say, oh, well, there's no benefit to going beyond a standard template. Well, what do you do when you have a patient who has radiographically positive nodes outside of that template? I think that, again, when we're thinking about this, we're sort of saying, well, we're taking it in the operating room to consolidate surgically as best we can. We should probably consolidate surgically, including any nodes that are reasonably accessible. And so I'd say there's still a role for, extended templates, especially if these are folks who have disease in that extended template, especially if it's still PET avid or still visible, and you don't think you've had a great local response in that nodal area or in that region. I'd say let the imaging guide you a little bit and don't necessarily throw out the idea of doing an extended lymphadenectomy for some of these folks. And certainly, I'd say because of some of this discrepancy we're seeing between local response in the index tumor versus in the nodes, by all means, still do a lymphadenectomy even in the consolidative setting.
So we as surgeons bring these patients to the operating room for consolidation, but I would be remiss if if we didn't discuss that there's other ways to consolidate cancer patients in this scenario, and that would be with radiation therapy. And, as you highlighted, these truly are multidisciplinary management decisions, at least at our institution. I'm assuming the majority of institutions where people are caring for these patients. So let's talk a little bit about radiation. What do you see globally as the role of radiation in this situation? And are there certain scenarios that make you think, hey, maybe radiation is better for this patient, that you'd favor it in lieu of surgery? And what do you see the role of radiation as we evolve in this era of question asking in this space?
So I see now that we're getting a little later into the podcast, you start asking the maybe more controversial questions. So I try to avoid it. We can hopefully avoid, surgery versus radiation discussion. The honest truth is there probably is a role. And, to be fair, there certainly I could envision a role for, surgical or radiation consolidation. But the honest truth is that our bias has been in favor of surgery. The cohort that we published, both our center and then some of the other work we're doing with teaming up with some other centers from across the country, has really all been surgical. And that's, probably reflects our bias as surgeons to some degree. But I think there's something to be said. And again, this is now where we're sort of, there's the data, which is, hey, we did, a couple dozen of these patients surgically. We're doing a few more on a trial that we can talk about later. And that's sort of the objective. Okay, this is what we're doing. And then there's like the interpretation of the data, right? So the data would be, 40% pathologic complete response, 80% pathologic downstaging. That's sort of the objective data. And then there's like the interpretation of it. And what I mean by that is the insight that we glean from having that knowledge seems to be valuable for our medical oncology colleagues. So knowing whether or not a patient has had a truly complete pathologic response to their systemic therapy seems to give the medical oncologists a lot more confidence in their decision to either continue or discontinue systemic therapy after consolidation, right? And with radiation, you don't necessarily get that. You're sort of limited to the sort of local response based on radiographic staging. But what you don't have is that true pathologic staging. Now, obviously, it's a morbid way to stage to take out somebody's bladder. But again, in the infancy, when we're just sort of learning about this new paradigm, learning about the role for consolidation, there is, I think, some value in getting a path report that tells you, okay, yeah, you actually thought you saw a positive node after EV-pembro in the left pelvis, but actually that was negative and there was another microscopic side of disease in the right pelvis that was totally radiographically normal, or vice versa. And same with the bladder, right? Like, yeah, you can sculpt the bladder, it might look fine. You can get a CT, you can get an MRI, you can do VIRADs, whatever you're doing to stage your bladders, and it all looks fine, but actually turns out there's still residual tumor in the bladder. And so, or vice versa. And so that sort of, again, when we're still so early in this and we're still learning about this and we're still gaining our experience with this, I think it is important to have pathologic staging. And again, I don't want to sound like a zealot for surgery. I think there's a role for radiation in the right patient. We have not done a ton of it. Most of our patients have been consolidated surgically. And again, not to sound like a zealot, but really insightful work from our colleagues who ran the Cysto trial, right? Looking at quality of life after, again, totally separate patient population, non-muscle invasive bladder cancer, looking at really, quality of life after cystectomy versus bladder preservation. And that's, not the same population we're talking about here. That's not a surgery versus radiation question. It's a very different question. But the only reason I bring it up is because it maybe gives us a little insight into the fact that maybe cystectomy, the quality of life impact is not quite the same as what we thought, right? And maybe, obviously it's a morbid operation, but long-term quality of life, these folks tend to not be as bad as we thought they would from a quality of life standpoint, self-reported, patient-reported outcomes. And I think Cysto trial was really insightful from that standpoint. So again, I don't want to get into the Pandora's box of surgery versus radiation or whatnot. All I can say is, most of our patients we've consolidated with surgery. Certainly there may be a role for radiation in well-selected patients, but I think early on when we're learning about this, I think it's helpful for us. It's helpful for us as a field to be able to report like, okay, this is the true pathologic, surgically resected, complete response, partial response, pathologic response in the primary, in the nodes. All that stuff is important as we're learning about this. And I think our medical oncology colleagues really appreciate having that information because it helps them guide next steps after surgery. They look at that path report and they say, okay, based on this path report, you need more systemic therapy, you don't, whatever. And I think there's maybe some value there.
So you alluded to this a little bit. I'm hoping you can expand a little bit on the medical oncology aspect of care for these patients, specifically the feedback that you've gotten from medical oncologists and how this has benefited them. And then also, how they feel like these patients do long-term, acknowledging that at this stage, most things are anecdotal. But if you could talk a little bit more about that, I think it'd be really insightful.
The best answer I can give you is that, the proof is in the pudding, so to speak. So if we look at, again, our initial cohort, but this trend seems to hold even after publishing that paper and looking at what's being done in other centers as well. In our initial cohort, 28, 30 patients, whatever, 80% of those patients did not go back on systemic therapy after surgery. So 80% of these folks had upfront systemic therapy, surgical consolidation, and then no additional treatment thereafter. And I think, that's a very roundabout way to answer your question. But what I would say is that only happens if you have, medical oncologists who are looking at these pathology reports and saying, okay, I have enough confidence here to say, based on the radiographic response, corresponding pathologic response, we feel comfortable enough with not giving additional systemic therapy 80% of the time. That, I think, answers the question as best I can, which is the information that our medical oncologists, and this fits anecdotally too, like when we're at these tumor boards, the med-oncs even will say sometimes, our med-onc colleagues will say, gosh, especially what keeps coming up sometimes in tumor board is, gosh, the EV is tough and we can't keep them on it forever. And there's some neuropathy stuff and whatever. And, we need to figure out a plan, and they've had a great response. Can we surgically consolidate and then maybe either just do pembro monotherapy after that or do nothing? And most of the time they're doing nothing, at least in this initial cohort of patients. And that's really guided by the pathology, right? That's guided not just by the imaging results, but also by the definitive pathology results that we gain insight into their true degree of response at surgery. Again, this is all still so early to know whether there's a true oncologic benefit to doing this surgery, right? And that's a different question to ask. Like if someone has a PT0, N0 resection, which is 40% of the people, could you have just observed that patient and not operated and they'd have the same result? That's something, gosh, we'll need a randomized trial to really answer that question robustly, like basically the Carmina, right, of Carmina trial at borrowed from kidney cancer. But anecdotally, right, in the absence of that trial, which hasn't been done yet, anecdotally, I think our medical oncology colleagues appreciate the pathologic staging and appreciate the opportunity to have an off-ramp from some of these systemic therapies.
Yeah, that makes a ton of sense. Let's move on to biomarkers. We've learned a little bit about ctDNA from some of the adjuvant immunotherapy trials in bladder cancer that have been published recently, but let's talk about biomarkers, ctDNA included in this space. What do you feel like the role is here? Where do you feel like biomarkers excel and fall short? And where do you see the future of biomarkers for these patients?
Yeah, good question. I was wondering when you'd ask me about ctDNA. It's like the single hottest topic right now in bladder cancer.
You knew it was coming.
Like, feel that way. Yeah. And, it's an interesting question. To be very fair, most of these patients that we've reported on did not have ctDNA. And there's a variety of reasons for that. But honestly, I think, to be honest, a lot of these patients were going in the operating room right after that EV-302 trial came out, early experience with consolidation after EV-pembro. We weren't using as much ctDNA as we are now. And it certainly wasn't front and center in our vernacular the way it is now. So part of this is just, we just don't have the ctDNA data for these patients to know. I mean, it was like a small handful of patients in this cohort even had ctDNA data. It didn't seem to line up one way or another, but I don't know, right? So I don't know what the future is of biomarkers. Certainly you can envision a world where, gosh, if you had the perfect biomarker, patient with advanced disease gets systemic therapy, has a, great radiographic or maybe even complete radiographic response, and then your biomarker is negative, can you simply observe that patient? Certainly that's provocative. I mean, that would be something we would love to be able to offer. That degree of personalized medicine would be amazing, right? Like, do the surgeries when you need to do them, avoid the ones that maybe end up being unnecessary, and really hone in on who you need to do this on. But I don't know that we're there yet, right? So ctDNA obviously is hot right now in bladder cancer. Probably the most compelling data on it so far is in the adjuvant setting, right? The IMvigor sort of paradigm, which is, okay, you've treated the primary. So you've done the cystectomy, the primary is gone. And now you're trying to decide, do they have, molecular residual disease? Do they have some micrometastatic disease somewhere that's not radiographically evident, but that might benefit, or that obviously would, based on this IMvigor data, that would benefit from systemic therapy? Obviously, in that situation, ctDNA is probably an excellent biomarker. But this scenario we're talking about, where the index organ, the bladder or the upper tract, is still there, I think ctDNA is a little harder to interpret, right? So if you have a patient who has, let's say they have positive ctDNA up front before systemic therapy, they get the systemic therapy, their ctDNA continues to be positive. Do you know whether that ctDNA is being shed from the primary tumor and nowhere else, in which case surgical consolidation might make a lot of sense still, or whether it's being shed from a micrometastatic site elsewhere when they have nothing in their pelvis, and surgical consolidation might actually not help that patient? And so I think that's the tricky part about ctDNA, is it's how do you localize it? So again, with IMvigor, it's easier to localize because it's not coming from the primary, because the primary has been removed or treated, whatever, they've had a cystectomy. So that eliminates the primary as a possibility. And so therefore giving adjuvant for positive ctDNA makes a lot of sense. Here, if you have a positive ctDNA, does that really localize it anatomically? Do you know that it's not coming from the pelvis? Like, I don't know that we know that. And I don't know that we can localize that just based on imaging and ctDNA alone. And the converse is probably true too, which is if their ctDNA flips to being negative after the systemic therapy, certainly that's encouraging, but does that guarantee that they'll have no residual disease in their bladder or in their pelvic nodes? I don't know that we know that yet. I think there's a lot of great trials that can be done around this to help answer that question. Certainly, and we'll talk about this at some point too, but we have Prospective trial that we're actually accruing to phase 2 for this exact sort of setting. And we're collecting ctDNA out the wazoo, before surgery, right after, at every time point we can possibly get, because I think there's so much to be learned about the role of ctDNA as a biomarker and other biomarkers, right? There's lots of correlative sort of translational work that needs to be done in this space to figure out what's what. But again, just conceptually, the way I think about it, I don't know if we can apply the IMvigor paradigm to this one-to-one just because we don't have the ability to localize in the pelvis versus elsewhere.
Yeah, so that's perfect segue to let's talk about future directions. And I do want you to talk about the trial that you're part of, that's Prospective as well. But first, and you've been taking care of these patients, I think, for a couple years now. Is that safe to say?
Yeah.
Have you seen anything change in the way that you take care of them?
Yeah, I mean, initially, I'd say that, and it's funny you asked this question, like, initially this was something where we would kind of look at each other in tumor board and it'd be like, well, I don't really know what to do. Nobody really knows what to do. We've not been in this situation. We don't have any data to guide us. Why don't you go ahead and take out the bladder? And that was actually one of the first ways I thought about, gosh, we should write this up. We should look at our experience. We should not just say, oh yeah, because tumor board said so, like that means it's a good idea. Like we need to pull together all of our data. We need to report on this. We need to learn as a group together so that our field can understand the role of doing surgery in this situation. But, I would say we've evolved from sort of the totally one-off, like, okay, the tumor board is recommending this crazy thing. This patient had metastatic bladder cancer and now tumor board is telling me I need to go take out their bladder. Like, what are we talking about? I think it's become a little bit more palatable, at least for us at our center. And even beyond that, I think now we've started to protocolize it, right? And so, starting to enroll patients on prospective trials and really doing it systematically and trying to do it in a way that's as scientifically rigorous as we can. Because, to be very honest, we're still learning. We wrote one little retrospective paper, but that doesn't mean we know everything about this. That's like just the tip of the iceberg, and that's like the pre-reading. Now we got to actually do the course syllabus and learn actually, with real rigorous ways.
Yeah, we've a long ways to go, certainly. Why don't you tell us a little bit about the prospective work that you're involved in and that's ongoing?
So this has been, I think, an evolution, and obviously you've been a huge part of this, Dan. I will take this opportunity to call you out as being really, to be honest, you're interviewing me as the host of this podcast, but really you are part and parcel in this, and this has been a team effort, and you've actually led, the first paper we wrote. You're the first author on it, and I think that you've had a huge hand in this. So the evolution of this has been that we started by saying, okay, well, what are we doing? We know here at Mayo, we were doing this. We really didn't know if other people were doing it or not. We first said, hey, why don't we reach out to our other sites, the Mayo Florida and the Mayo Arizona folks, and they were doing it. So we said, let's pull our data together and let's publish this. So that was the first sort of thing we put out there. And it's like your quintessential retrospective study of a couple dozen patients, like admittedly, and I know that, you wrote this paper, but it's like the lowest scientific rigor of any study you could do. We're just trying to start the conversation. We're not trying to make conclusions. We're just trying to start the conversation, right? And I think the next sort of logical step after that is to say, start putting feelers out there and talk to other folks at other centers and say, hey, we've started to do this. Is anybody else doing it? Or are we crazy? The only crazy ones doing this? And it turns out you sort of start to put the feelers out there and people are like, oh yeah, I've done a couple of those. And, the med-oncs always tell me I need to do it. And tumor board always says you should do it. And I don't really know if it's the right thing to do, but we've been doing them. And you start to sort of get that sense that this is kind of happening out there in other places too. And so the next phase of this, not to be a spoiler or steal your thunder, but, Dan, you're obviously going to help write this up too. We just put together an abstract from the AUA with like 10 or 11 centers from across the United States, all of whom are doing this. Again, still anecdotal. That one's a little bit more strict in terms of who we're including, who we're not including. But by and large, most of the results are pretty similar to what we saw the first go around. But it just it just builds our understanding of this, establishes that this is happening, for better or worse, this is happening. Here's the safety of it, right? Here's the safety profile of this surgery. Here's the pathologic downstaging. Here's the complete pathologic response, like just sort of defining that initial basis, right? And I think the real rationale for these retrospective papers is to set the stage for doing the more rigorous studies. And so there may be many more studies out there than I know of, but the two that I'm familiar with, so there's the Consolidate trial, phase 2 prospective trial coming out of Yale, I believe. And then the other is a plug that I'll put in for our own trial being led here at Mayo Clinic, really spearheaded by my colleague in urology, Paras Shah, and our colleague in medical oncology, Jake Orm, really, really doing the bulk of the heavy lifting. The visionaries behind that trial, can't give them enough credit, but basically it seems like both of these trials are very similar. Ours at Mayo is called CAST AI. The Yale one is called Consolidate. Every trial needs a good acronym, but the idea behind them is the same, which is these are single arm phase 2 studies. So we're not randomizing folks yet, but we say, okay, take folks who have either nodal metastasis or distant metastasis. So N positive or M positive, nodal or distant disease at diagnosis. They should be reasonable surgical candidates. Put them on protocol so they get EV-pembro upfront, so upfront systemic therapy. And then, if they've had a favorable response, either a partial or complete response radiographically, then they go on to get surgical consolidation. So, and again, on our protocol here at Mayo, again, led by Jake and Paris, that's happening in conjunction with lots of exploratory biomarker testing that's going on behind the scenes. And Jake's got a lab that'll sort of help interpret a lot of that data that comes out of that. But the idea is we sort of protocolize this, right? We say, okay, yeah, it was a little weird to go out and start doing these cases just off the cuff because tumor board told us to, but we did. And it was probably a really insightful experience. Now let's protocolize it. Let's have a registered clinical trial, and others obviously have had this same thought. But I think these initial phase 2 studies are going to give us a lot of insight into, okay, what is the true pathologic downstaging rate? What is the true complete response rate? But actually the primary endpoint for both of those studies is the 1-year progression-free survival, right? So you start to get to this question of, okay, like, let's start to define the oncologic outcomes, right? Our initial papers that we're writing on this are really looking at, okay, what's the safety? What's the pathologic results, whatever. Like our median follow-up was maybe 10 months or so. It's too early to know what the long-term oncologic results are, but that's the primary endpoint for both of these studies. It's funny, they're almost identical in the way they're designed, but 1 year, progression-free survival after this consolidative surgery. Again, that's still sort of single-arm phase 2 type of learning. And then ideally, the holy grail, the real true crux of this question is, are we actually helping these people by taking out their bladders or taking out their upper tracts if that's where their primary was? And, we're sort of dancing around that question a lot. And even the Consolidate trial out of Yale, the CAST-AI trial that Paris and Jake are running here at Mayo, we're still sort of dancing around that. But these are necessary steps in the sort of scientific process, I think. But ultimately, like, do we know 100% that these patients can't be safely monitored? I don't know that we know that. And I think the only way you can really answer that question is to randomize them, right? And that's going to be fraught with challenges and logistical issues and the palatability of randomizing people after systemic therapy to observation versus cystectomy. And it's going to be, a whole Pandora's box. But to be honest, like that's the only way we can prove, scientifically prove that there's a true oncologic benefit to doing this. Until then, I think we're still sort of getting at it a little bit tangentially, but that's kind of the evolution I see, right? You start by publishing some small retrospective studies, then you start to do the phase 2 trial, then you start to get a little bit more of the biomarker data. And then eventually, once you have really thoughtful sort of randomized trials you can design, you start to actually design those. But it's iterative, right? Like we need to learn a little bit at the very beginning about safety of this surgery before we start designing a trial protocol to people. So that's kind of how I think through, and I'd say we're still in the first phases of that sort of long-term timeline.
Yeah, makes a ton of sense. 5 years from now, in your opinion, if you had to make a guess, where would we be when we think about managing these patients?
Yeah, great question. So hopefully 5 years from now, we have maybe data from at least two prospective single-arm trials that have taught us a little bit more systematically about the sort of safety and efficacy of consolidative surgery. I think, in an ideal world, we'll be in a place where we've got a really well-oiled biomarker that can tell us who needs this and who doesn't. Those things take a long time to flesh out, especially if you're talking about long-term prospective randomized trials. 5 years may not be enough, but that's the ideal.
All right, great. So we've been talking for a while now, and I want to get your parting thoughts and wrap things up. So, before we end, I want to get what you feel like is an overall take-home message in this space and what you want to leave listeners with. And I also am hoping you can maybe provide some guidance for a urologist who's engaging with one of these patients for the first time, seeing one of these patients in clinic for the first time, taking one of these patients to the OR for the first time. Is there any guidance that you'd be able to offer, someone in that position?
First and foremost this is not, by any means, this is not like the standard of care. Okay, so do not think, because there's like some anecdotal data out there that all of a sudden this is the standard care. This is not. So patients who have advanced urothelial carcinoma should continue to get systemic therapy as the backbone of their treatment. And that's it. So we should maybe keep that in the context, this whole discussion in the context of the fact that that is the standard of care. Now, if you are faced with this scenario, right, you have a patient who had advanced or metastatic urothelial carcinoma, they've had a great response or doing well with systemic therapy, or they're not tolerating, and their medical oncologists are maybe talking to you about this. I would say always, almost always, like have a multidisciplinary discussion. If you have access to a tumor board, bring that case to tumor board, have it discussed with your colleagues, have input from the medical oncology folks, review the images, with radiologists if you can. Don't do this in isolation. This is still so far from what's sort of within the guardrails of guideline-based treatment, right? This is stuff that we're doing case-by-case basis, clinical trial. Like this is stuff that should not be thought of as like, oh yeah, well, I heard this podcast about consolidative surgery. I'm going to go ahead and do a bunch of them. These are still multidisciplinary discussions. The second thing I would say is if you have access to clinical trial, any sort of clinical trial you could put this patient on, go for it. We obviously have one here at Mayo Clinic. Yale sounds like they have one. There may be others out there. If you have access or the patient has an ability to get to one of these places that's enrolling, gosh, that is going to be the single best thing you can do because we need to learn, right? We need to learn about this and we need to, as a field, start to understand and grow our body of literature to support or refute whether or not this is even a good idea. So number one, don't do this in isolation. Don't be a cowboy, float the boat, get your colleagues from other disciplines involved in that discussion. Number two, realize that this is something that is being done, but is not necessarily the standard of care. Number three, get that patient on a clinical trial protocol if you can. If you can't and you're still going to offer this, then I think you got to be very upfront with these folks and say like, look, there's not great evidence to support that taking out your bladder or taking out your upper tract is going to offer long-term oncologic benefit. And I've told every single patient that because I think it's important to be upfront. We simply don't have long-term randomized trials to say that this is a good thing or that this offers a discrete benefit that we can measure and that's been proven. We're not there yet. We're simply not there yet. And so with all of those caveats, I would say if you're going to dabble in this, or if you're going to do it, ideally don't make this your first cystectomy you ever do. If you don't do cystectomies routinely, probably refer this to somebody who does do cystectomies routinely. Whoever you send your cystectomy candidates to right now for localized disease, that probably should be your same pipeline for patients who have advanced disease with all of those caveats. And if you do cystectomy and you're thinking about, taking on one of these cases, you could read the papers and look for yourself at what the morbidity of that surgery is like. But I think it's pretty similar. And I think if you're comfortable with cystectomy, then certainly this is within your domain and from a surgical and a technical standpoint. So don't be shy about doing that. But again, all those caveats still apply. And again, trial is going to be the best way for us to take care of these patients now so that we can continue to offer them the best care in the future.
Amazing. Well, Dr. Khanna, thank you so much for joining me today and spending a good portion of your time enlightening us on this topic. I thought it was an incredibly insightful discussion and, I found it useful and I hope our listeners enjoyed it and found it useful as well.
Yeah, thanks so much for having me.
Thank you so much for listening. If you haven't already, make sure to subscribe, rate the podcast 5 stars, and share with a friend. If you have any questions or comments, DM us at _BackTable Euro on Instagram, LinkedIn, or X. BackTable is hosted by myself, Ruchika Talwar,
Jose Silva,
and Suzette Sutherland.
Our audio team is led by Kieran Gannon, with support from
Aaron Bowles,
Gabe D'Agrazio,
and Josh Spencer.
Design and digital marketing led by Brian Schmitz.
Social media and PR by Chi Ding.
Administrative support provided by Judy Dela Cruz.
Thanks again for listening and see you next week.